uh, oh, go ahead. I was just going to make.
Okay,
I
well,
was going
welcome
to
everyone.
go ahead.
Welcome to our March forum. Just a couple logistics before we get started. We have an amazing speaker on kidney transplant candidate selection, compliance, adherence, and person-centeredness by Dr. Kate Butler. Just a quick land acknowledgement if you all wanted to just read this slide as we always have in the beginning. And then just so you know, today's presentation will be recorded, and if the speaker has given us permission, it will be posted on our website. That is always depending on the speaker, so feel free to email us with any questions. And then, so the objectives of today's presentation are to appreciate the meaning and use of adherence to medical recommendations as a criterion for kidney transplant candidate selection, to consider implications of an adherence criterion from the perspectives of utility, equity, and person-centricity in transplant candidate selection. And 3, identify strategies to reinforce the ethical foundation of the kidney transplant selection process. And just to disclose, the speaker and none of the planners have any relevant financial relationships to disclose. We will be sending out an evaluation survey after today's session. It should pop up automatically. And if you are a UW learner, unfortunately, the CME cloud is down today. So I will send this link for a form that you can fill out that will count as your attendance. Unfortunately, you are not able to text for attendance today. We will also be marking attendance by the evaluation survey if you are not able to fill out that form. And just so everyone knows, we have our advanced training in healthcare ethics program going on. We will be restarting the program in the fall, but our third course for the spring will be starting next month or the end of this month. Applications are due this weekend. If you have any questions, feel free to send us an email. You can always find more information on our website. And then for those of you that are familiar, we have our annual summer seminar and healthcare ethics conference happening this August from Monday the 4th to Thursday the 7th for 3.5 days. We also have a new program director, Dr. Noah Braggs, and we will be having a lot more interactive components and great expert-led discussions. We hope to see you there if you have any interest in healthcare ethics. And then really quickly, I'm going to hand it off to one of our own, Crystal Brown, about a bioethics research study that you have the option of participating in.
Thank you so much. I'm just going to take 2 quick minutes to talk about a study that myself and Gina Campelia, who's one of the bioethics ethics consultants here at Harborview, are doing, funded by Greenwall. It's looking at the use of restorative justice in the medical setting to address patient and family concerns about racism and other identity-based concerns. The QR code will take you to a short anonymous survey that is actually taking people less than 5 minutes to complete. And then you'll also have the option of leaving your name and email address if you're interested in doing a survey, for which you will be compensated with a $100 gift card. If the QR code is not working for you, I'll drop the link in the chat. And then we have a lot of physician respondents, but we're really interested in getting responses from nurses, therapists, social workers, just people who are not physicians, basically. If you have any questions, there's my email address, and thank you for considering. Thanks.
Yeah, thank you, Crystal. This is a great opportunity if anyone is interested in just bioethics research. And if you have any questions, feel free to send Crystal an email. And some future forum dates. So again, these happen every second Wednesday of the month from noon to 1 on Zoom. Next month, we have a great discussion about end-of-life legal concerns with John Gibson, Michelle Nelson, and Dion Williams. After that, we will have one in May with Dr. Lori Bruce on community ethics. Both are going to be amazing discussions and great topics, so we hope to see you there. So last but not least, to introduce today's speaker, Dr. Kate Butler is an assistant professor in the Division of Nephrology at the University of Washington. an investigator at the UW Kidney Research Institute and Seattle VA Health Services Research and Development Center of Innovation, and a clinical nephrologist at the Seattle VA. Her research is framed by bioethical theories of distributive justice and centers on healthcare settings where patient experiences and treatment options are shaped by resource limitation, including in the kidney transplant evaluation and selection process, and episodes of resource scarcity during the COVID-19 pandemic. She also studies end-of-life care and intensive medical interventions for older adults with kidney disease. So it is my pleasure to introduce Dr. Kate Butler.
Thanks, Carrie. Let me just get myself set up here. And maybe you can let me know, does that look all right?
Yes, that's perfect.
Okay, all right, thank you. I was just about to say, as we were waiting to start, that one of the conferences I'd been to recently had kind of hold music as a kind of interlude before someone started speaking, to avoid that kind of Zoom silence that we've come to experience. And I wonder, what that music would be for the Harborview Ethics Forum, what the theme is there. Maybe you can drop recommendations in the chat. It's an entirely unsanctioned request on my part. But at any rate, I really appreciate the invitation to speak again. I was here 5 years ago in February of 2020. I had a different picture then. And I was here at the Harborview Ethics Forum presenting on these rare situations when clinicians might evoke this sense of resource scarcity in delivering dialysis care. And this, I think this was the last presentation right before we went virtual when we were then under lockdown. And see that we even had lunch provided at that time. It was a different world. And of course, this topic was a little bit ironic because, little do we know that Harborview and other institutions are about to face this crisis of resource scarcity related to dialysis and other treatments. And the idea of having to balance patient care with rationing treatments at the bedside became this regular challenge that many of us experienced. So much to say about that experience, of course, but my work this is kind of an example, has tended to revolve around these various situations where clinical care decisions are overlaid with considerations of resource scarcity, either explicitly or implicitly. And I'm interested in how the healthcare system reacts to these situations and the experience for patients and clinicians. So a few things about me to give you a sense of what I'm bringing to this topic. I'm a nephrologist at the Seattle VA. My clinical experience with the kidney transplant evaluation is as a general nephrologist working with primarily older adults. I'm also a health services researcher. I was trained in bioethics here at the University of Washington. I suspect I can't see the audience, but probably some of my teachers in the audience. And these are some of my mentors and supporters and organizations that support my time. So today I want to dive into the specific instance of this theme that I'm describing, the use of adherence with medical recommendations as a requirement for kidney transplant candidacy. And we'll take this in kind of 3 steps through the talk. First, I'll talk about the state of affairs. So how is adherence used as a criterion for kidney transplant candidacy? The majority of the talk will be an ethical analysis of implications of this practice in terms of utility, equity, and person-centeredness. And then finally, we'll end on some possible strategies to reinforce the ethical foundation of kidney transplant evaluation selection process. Also some gratuitous kidney-based art that I found on the internet. So starting with adherence as a criterion for kidney transplant candidate selection. So for the uninitiated, kidneys, they are important. Kidneys have a bunch of complex functions in the body. Many things cause kidney failure. By far the most common is diabetes. And as kidney function gets lower, kidneys are less and less able to do these functions. Patients rely more and more on medications, dietary restrictions, until reaching kidney failure. And at that point, treatment options include conservative kidney management, so focusing on medications and dietary restrictions without resorting to kidney failure, kidney replacement therapies, knowing that life is often shorter. Most people start on dialysis, either hemodialysis or peritoneal dialysis, and that these treatments replace some but not all of kidney functions. Dialysis is also incredibly time-consuming and burdensome. And the last option is kidney transplant. So kidney transplant is also not a cure for kidney failure. It still entails quite a lot of work for patients, but for many, it can offer better quality of life and length of life compared with dialysis. And that's really for a broad swath of patients. So there's multiple really nice and compelling studies of the last years that have reinforced that transplant can be a benefit for many people, including older adults, frail older adults, people with multiple chronic conditions. But we know that the majority of people will not receive a kidney transplant. Just to give you an idea, there's about 136,000 new cases of kidney failure in the US every year and 26,000 transplants, majority of which are deceased donor transplants. And the reason there's this gap is two. One, for some, the risk of surgery and immunosuppression will be too great. They may decide they don't prefer to go the route of transplant. And then also, the supply of kidneys from deceased donors is really outstripped by demand. And not everyone who's in need has a willing and able living donor that could donate to them. And this means that a lot of people who are deserving of a kidney will not ultimately get a kidney. To receive a kidney transplant, folks have to go through this series of steps that I've really basically outlined here. They have to connect with a nephrologist, have maybe an initial discussion about their interest in transplant, be referred to a transplant center, undergo physical and psychosocial evaluation, then be selected by the transplant center, and as a candidate and search for a living donor and or be added to the national wait list for deceased donor transplant. And the majority of our research, our discussion, ethical discussion, policy discussion has focused on this last step of the kidney transplant evaluation process where folks are selected among the national wait list for deceased donor transplant. And this situation is an issue of how to allocate a scarce resource across a population in need. There's multiple principles of distributive justice that inform our current allocation system. And among these, the most commonly cited are this need to optimize utility and equity. So utility is this idea that the entire enterprise really of organ transplantation is undertaken to benefit this group of ill patients. So this idea that we should be optimizing the overall good, the overall benefit to this group could be considered a primary reason for the program. And this principle of utility guides practice around ensuring that kidneys are, for instance, well matched to recipients, that kidneys are allocated to patients who are not too far in distance from where the kidney is, the donor kidney is, to avoid the kidney being out of body for too long. There's a list of sort of factors related to utility that we might go through. And there's also a need to support equity in the allocation of these donor kidneys. So equity centers on distributing organs in a way that all patients on the wait list have a fair opportunity to receive a kidney. And the main way that this is manifest on the kidney wait list is those who've been waiting the longest are prioritized for allocation. Our guidelines also refer to a principle of respect for persons in organizing the system of allocation. And respect for persons refers to this moral requirement of honesty and fidelity to commitments made, refers to respecting individuals as autonomous beings. And in the context of the waitlist allocation, respect for persons is applied relatively narrowly. I've made it a bit smaller here. And often interpreted as patients should understand the process and should be empowered to decide against transplant, decide against treatment if they choose. Many of you may have seen this recent New York Times article on the waitlist allocation process, and they have a really nice visualization of how the selection process works, how it tries to incorporate both optimizing utility and also respecting fairness for people on the wait list. So again, to underline, all of the people who are on the wait list are deserving of a transplant. Resource scarcity means that not all who are in need and wish for a treatment will receive that treatment. And this sets up this context, this idea of a tragic choice. No strategy of allocation is going to feel really good. There's always a sacrifice of one value or another. And distributive justice deals in making the best of this tragic situation or minimizing ethical harm. But that does make it difficult to determine how to balance these competing draws to maximizing utility and respecting equity. So instead, we might aim for this idea of a fair process described by Daniels and Sabin. And that is a process where criteria are appropriate, or the criteria we end up with are appropriate from the perspective of those affected, so patients, clinicians. The criteria are transparent, they're revisable, and they're regulated in some way. Unfortunately, again, for those who read this New York Times article, the very point of that article is that these rules can be and have been bypassed to undercut what's intended to be a transparent and standardized system. And this realization has had a huge impact on fairness, on sense of fairness and trust in the organ allocation system. And I will say a system that was already under a huge amount of scrutiny over the last few years. So we're going to set that very important discussion aside for another time and move upstream in this evaluation and selection process. So these earlier steps in the evaluation selection process have more complex goals. So like any other preoperative evaluation, part of this process is making sure that an individual person is personally healthy enough to benefit from transplant. So it's like a preoperative evaluation process. We want to ensure that the individual patient would do okay in the perioperative period, would do okay with lifetime immunosuppression. But at the same time, this is also a process of selection. It's a process of narrowing the number of potential candidates for kidney transplant. So there's kind of dual purposes to this upstream part of the transplant evaluation process. And just to underline or sort of confirm that this is a process of selection, not just the usual kind of perioperative evaluation process. This is a flow diagram representing some preliminary data from a study we're currently conducting to better understand patterns in these early steps in the transplant process. So you can see that among about 54,000 people with advanced kidney disease that we studied here, about half had a mention of transplant as a treatment option in their care. And about a third did some sort of evaluation or treatment to see if they could be a candidate. But only a small minority, about 9 or 10%, were ultimately waitlisted or received a kidney transplant in this cohort. Big caveat that this is preliminary data and our follow-up time is limited to a few years after someone first developed advanced kidney disease. So it's possible that this group of people who we didn't follow to the end of their course may have engaged in the kidney transplant process. But just the fact that so many people in this cohort died makes me pretty confident that at least this pattern is consistent with longer follow-up, but we'll continue to study. So what are the other goals or values, or compared with the process that we just talked about, what are the goals or values underlying this approach to this part of the transplant evaluation selection process? Well, unlike the kind of clinical practice guidelines that we have for the wait list, or the kind of position statements we have for the wait list approach, there's less explicit statement of what the purpose of the evaluation and selection process is in terms of these values. But we could presume that the principles that guide the waitlist allocation should also guide this part of the process, that is maximizing utility and equity. But the transplant evaluation process is, as I say, also a kind of preoperative evaluation that's designed to ensure that individual patients are in a position to benefit themselves from transplant. So for this reason, this concept of respect for persons, I think, has to take on a broader application. We need to consider how this evaluation process supports features of person-centered care that we'll get into in a little more detail. So as currently designed, the kidney transplant evaluation process involves a somewhat checklist-style deep dive into different aspects of patients' physical, psychological, psychosocial health and well-being. And this is a list from some of our clinical practice guidelines. And as you see, one of the main criteria for transplant candidacy is adherence to medical recommendations. And this is the part of the selection process that we'll dig into a little bit more. So this is a PubMed search of a few terms over time. I have the term compliance here in gray and adherence in blue. And you see that the term adherence has slowly become more common in medical parlance compared to this earlier term compliance. So compliance could be defined as the extent to which a person's behavior, taking medications, following a diet, executing lifestyle changes, corresponds with recommendations from a healthcare provider. In contrast, this shift to the term adherence is intended to make a distinction between a more paternalistic perspective of imposing the right kind of treatment on an individual to now referring to a person's ability to refer to treatments that they themselves had agreed upon. So the extent to which a person's behavior corresponds with now agreed upon recommendations from a healthcare provider. So increasing recognition of this need to respect autonomy in patients' medical decisions. So how does this requirement for adherence play out in the kidney transplant evaluation process? Here's, again, some examples from clinical practice guidelines, how they describe the assessment for adherence in the kidney transplant evaluation process, and how we assess adherence. In our clinical practice guidelines, we tend to focus on understanding adherence as a barrier to care outcomes, and the intention of evaluating adherence is to be able to address these barriers, help patients overcome these barriers. And the guidelines don't specifically recommend entirely excluding a patient as a candidate, except in the extremes of non-adherent behavior, when there's concern that the individual patient themselves is unlikely to benefit from a transplant. Actual practice is a little bit different than these guidelines. In practice, there's huge heterogeneity in how adherence is assessed and how it's used to determine transplant candidacy. There's no standard tool or measure, but commonly adherence is judged based on a person's ability to attend and complete dialysis sessions, to attend clinic visits, to adhere to dietary recommendations. So the next part of this talk, we'll take a look at the ethical implications of adherence as a criterion for transplant candidacy. First, this utilitarian rationale for adherence. So again, we have an obligation to maximize utility of a scarce resource, in this case, deceased donor kidneys, and distribute across a population of people in need. So we can think about this selecting for patients. This is selecting for patients who are most likely to survive with a donor kidney, survive for the longest, people who are likely to experience the longest period of a functioning kidney or kidney years. Adherence to immunosuppressants in the post-transplant period is very challenging because the pharmacodynamics of these medications are complex. They need to be taken very precisely. They interact with a lot of other medications and can have side effects. This is a meta-analysis from 2004, and it showed that medication non-adherence was estimated at about 22% of people of adults with kidney transplants, and kind of pointed this out as a major avoidable risk factor for kidney transplant loss. So our intention in the pre-transplant period is to select for people who are likely to adhere to treatment recommendations in the post-transplant period. But we think about this a little bit more deeply. There's a few premises underlying this adherence criterion. First, that the pre-transplant adherence does predict post-transplant adherence. And second, assuming that it does predict post-transplant adherence, that the degree of this predictive power and certainty is sufficiently strong to account for any downsides of this selection criterion, as we'll get into a bit, downsides such as concerns for equity and person-centeredness. So let's think about this first premise. Does the pre-transplant adherence, do pre-transplant adherence patterns predict post-transplant adherence? It's a pretty natural assumption that this would be the case, but there's reasons to question. So first, transplant can be a huge major life transition and experience. And it's really natural for people to change their behaviors in the face of life changes. Treatments pre-transplant, they're being evaluated, are also just quite different than what someone experiences post-transplant. And dialysis in particular is a hugely personally and socially challenging treatment to complete. I wanted to share this one example from a patient that we interviewed that I think really illustrates this kind of tension. This is a patient who was receiving dialysis and being evaluated for kidney transplant, but had actually already received a liver transplant, so was living with a liver transplant. He says, I have to go to dialysis, otherwise I'll be declared non-compliant, and that will put me off transplant. Non-compliance is a buzzword for he's not going to take his transplant meds after transplant. Of course, I've been compliant for 27 years with my liver transplant, otherwise I would have rejected a long time ago. So just a reminder that we tend to forget that adherence is not just one thing. Ability to do treatments hugely depends on the treatment itself and how that fits into one's life circumstances. Some more scientific evidence about the predictive power of pre-transplant adherence. There's a few kind of a body of studies related to this topic, and results are mixed. I want to highlight one recent study. They looked at about 9,500 transplant recipients, collected information on pre-transplant measures of adherence. So in particular, adherence related to, in a few different ways, to dietary restrictions, hyperkalemia, hyperphosphatemia, intradialytic weight gain, all relate in some way to dietary restrictions. And they also looked at measures of adherence with dialysis. So people shortening their treatments on dialysis or missing dialysis treatments. And then they followed to look at 1 year donor kidney failure as a primary outcome, and whether these exposures predicted this outcome. They found that several different things, high phosphate levels, water weight gain between dialysis sessions, and shortened treatments were associated with increased risk of loss of a kidney transplant after 1 year. So for example, people who had documented shortened dialysis treatments had a 50% increased risk of mortality at 1 year, of kidney transplant loss at 1 year. And that's very concerning. That's a big difference. So this analysis at least suggests that there's some real associations between pre-dialysis adherence and post-transplant outcomes. But before we go on, I wanted to think again about that second premise, and that's that the predictive value of these associations has to be substantial enough that it might outweigh the drawbacks of using adherence as a selection criterion. So in this context, it's helpful to think about absolute risk. So some additional information, the 1 year graft survival among all comers in the US population is quite good. It's 97.6% at last check. So that means that a 50% increased risk would be about 1.2 greater absolute risk of kidney loss, or 96% risk of kidney loss among those people who have this documented non-adherent behavior. Just to drive home, there's this behavioral economics idea that tells us that people tend to overweight differences at the extremes of percentages. So, the idea is that a change of 96 to 95% seems like a bigger change than a change from 51 to 50%. So just to kind of drive this home, I wanted to visualize this difference. Here I'm representing the outcomes of the group who had documented full dialysis treatments before transplant versus those who had documented skipped or shortened sessions, and loss of kidneys within a year is represented in blue. So of course we would, if these two groups were entirely random, we would choose this group, to try to optimize. One less kidney loss in a year is a huge deal. But on the whole, we might also say that there's this kind of differentiation between groups doesn't offer a huge amount of certainty and gives maybe a modest magnitude of difference in outcomes across these groups. So again, ultimately, we have to decide if this increased risk of kidney loss and the certainty about who's going to lose a kidney is significant enough to outweigh the drawbacks of using adherence as a selection criterion. So let's go on to those other principles of allocation. First, we'll think about equity. So this need to promote equity and access to preferred treatment options across the population in need. Unfortunately, we see already major disparities in access to kidney transplant and disparities in access to the transplant waitlist along the lines of race, socioeconomic status, gender, geography, others. So what equity would have us do is at the least not exacerbate existing disparities and potentially even work to address these health disparities by giving additional support, for instance, to those who are already disadvantaged. The requirement for adherence really does interact with social determinants of health in complex ways. Our ability to adhere to treatment recommendations is, as we know, hugely entangled with a range of contextual factors. And again, I think it's especially true of a personally and socially challenging treatment like dialysis. One's ability to complete these 4-hour dialysis treatments 3 times a week has just got to be shaped by access to transport. Some people's more than others need to work, access to backup care for children or other dependents, many factors like this. Adherence behaviors also intersect with some of the other factors that are explicitly evaluated in the transplant psychosocial evaluation. So this is a list of factors considered as part of the psychosocial evaluation and the proportion of transplant programs that consider each of these factors. So patients are, as you see, often evaluated for housing stability, ability to transport, community and family support, and all these factors will also relate to one's ability to adhere to treatment recommendations. So maybe kind of a double hit for some of these folks. Also wanted to make the point that implications of adherence will differ for groups who've been historically underserved and mistreated by the healthcare system. This idea of adherence or compliance suggests a right way to go about treatment. And who decides that right way? It tends to be the healthcare system, and a healthcare system that is made up of majority white and privileged clinicians. This reminds me of this really excellent work from the anthropologist Cheryl Mattingly. She did an ethnography to study Black parents with sick kids in pediatric clinics. And she describes this sort of meeting of two cultures, parents and clinicians, and how parents were in the position to recognize the need to assimilate or play by the rules of a healthcare culture in order to get the care they really needed for their kids. And this requirement for adherence, especially when the stakes are high, like they were for these parents, like they are for people with kidney failure, has concerning implications for limiting the voice of people not represented in our current healthcare environment. So finally, let's think about adherence selection criterion and their implications for person-centeredness. This is a definition of person-centered care from Don Berwick, the CEO, or past CEO of the Institute for Healthcare Improvement. And he describes person-centered care as the experience, to the extent that the informed individual patient desires it, of transparency, individualization, recognition, respect, dignity, and choice in all matters, without exception, related to one's person, circumstances, and relationships in healthcare. So person-centered care really represents a paradigm shift from disease-based medicine. Under person-centered care, this right treatment doesn't really exist as an archetype separate from individual context and needs. Person-centeredness in the kidney transplant evaluation process means respecting autonomy and dignity of individuals. And we can think maybe of this concept of person-centeredness as another step in this evolution of concepts from compliance and adherence. Here, the term person-centeredness is cropping up in the last few decades. And to give another definition, I'd say under a person-centered paradigm, in thinking about adherence, a lack of fidelity in completing treatment plans points to a lack of fit between recommendations and patients' lives, priorities, and contexts. The problem is the right treatment rather than the patient. And the appropriate treatment requires individualization and customization. So in other words, person-centeredness doesn't seem especially compatible with the concept of compliance or maybe even adherence. I do want to address this. Person-centeredness we increasingly use freely, and I've heard this kind of response that person-centeredness is kind of like apple pie, right? It's nice. It's nice to have everyone. No one's going to argue with saying that we should be more person-centered, but what does that really mean, and does it really have much force? So focusing on person-centeredness, focusing on an individual is valuable for everyone, but I think there are certain situations when person-centered approach most differs from a traditional disease focused care. And in those situations, we can see how it's especially important. So a person-centered approach is especially relevant for folks with multiple chronic conditions. So situations where an approach based on evidence derived for particular individual diseases may mismatch with the approach for other diseases, and on aggregate for a particular person may not make sense. It's especially important when longevity is limited. So treatments that focus on future benefit, like treatments focused on risk reduction, may not have a lot of value if longevity is already limited for other reasons. And values like quality of life may take priority. It's also especially relevant when treatments themselves cause significant burdens that interfere with life flourishing, other life goals. And all of these are more common for older adults with complex illness. So I'm going to argue next that the kidney transplant evaluation process is exactly that type of situation where person-centered care should be relevant. Half of Americans with incident kidney failure are 65 years or older, and people with kidney disease also tend to have a substantial number of other chronic conditions. This is a study looking at different medical specialties and the ratio of number of chronic conditions relative to a family medicine practice. And we see that nephrologists up here have 3 times the number of chronic conditions among their patients compared with family medicine physicians, the highest of all these specialties studied. Doesn't include geriatrics for some reason, but I think still significant. So again, I think this is exactly the group for whom applying an algorithmic approach and requiring adherence to standardized treatment recommendations could be harmful. The transplant process is also not just a short-term trial period after which patients return to their usual care. Back to this preliminary data that I showed you before describing the transplant evaluation process, we estimated that roughly 30% of cohort members did some sort of evaluation or received treatment recommendations related to kidney transplant. And they spent an average of 1.3 years in the evaluation phase before that process ended. They died, or more rarely, they were referred on to a transplant center. So this evaluation process affects a large portion of patients for long periods of time. I also want to talk a little bit about the experience of the transplant evaluation from the perspective of patients, from descriptions of clinicians. So I'm going to highlight some of the qualitative data that we've gathered to get a better sense of how this adherence criterion manifests in clinical care. This is from our work both analyzing clinician documentation in the VA electronic health record and in interviews with older adults and their family members about the kidney transplant process. So first, patients, maybe not unexpectedly, are very motivated to do what is needed to receive a kidney transplant. Transplant, for many of them, promised an escape from the prospect or reality of life on dialysis and a return to normalcy. One participant described it as a chance to continue a life that you had. And because transplant was seen as such a desirable goal, many patients were willing to do whatever was asked of them, even if they found aspects of the evaluation process to be excessive, performative, or uncomfortable. One participant put it, why be worried about minor discomforts when you're having a procedure that's going to save your life? So engaging in the evaluation process could also require this shift of mindset where abnormal test results that would ordinarily be viewed as benign or part of normal aging, were now considered potential disease states to be diagnosed, evaluated, and treatment. And, big picture, this is a shift from a person-centered approach to care to a more disease-based focus. And this is a quote from a patient with a prostate biopsy that was equivocal for cancer, but who felt obliged to undergo treatment. He said, "It happens to most guys. It may not have been cancer, but you've got to take care of it. Otherwise, they won't give you a transplant." The ways that patients and clinicians described required tests and treatments as part of the transplant evaluation process was also more reflective of what we might describe as compliance rather than adherence. That is, there seemed to be little evidence of shared decision-making. Here's a quote from a daughter of a patient describing how continuing cholesterol medications was required, even though it didn't seem needed to her. They said the protocol is you have to take cholesterol medications even if you're not needing it. Her cholesterol has been pretty much on the lower end, but she's still taking the cholesterol medications. We don't want to be non-compliant. And local clinicians who might usually be in the position of supporting shared decision-making seemed often to also not really understand or agree with transplant requirements, but were obliged to complete tests and treatments to support their patient's candidacy. Here's an example from a cardiologist. He said, "We're reluctant to perform cardiac catheterization, but criteria for kidney transplant are different." There were also descriptions of how the transplant process was explicitly a test of patients' adherence. One quote from the electronic health record said the entire transplant evaluation is somewhat of a litmus test to see if he could follow through appropriately with each step. There were also signifiers of how patients were closely surveyed to ensure that they were being compliant and acting in a way that was expected of transplant candidates. A quote from the EHR, "After checking in at the transplant center, he went to a nearby casino without alerting the floor. He was cautioned about such behavior being perceived as non-compliant." So to sum up the implications of this adherence criterion for each of these principles that we're bringing to the transplant evaluation process, the utility of adherence criterion is uncertain. There are concerns for equity, for the impact on equity. Adherence is shaped by social determinants and likely to disproportionately affect disadvantaged and minoritized groups. There's also concern for impact on person-centeredness of the transplant evaluation process. This idea of compliance or adherence, especially as we see it manifest in the transplant evaluation process, seems to assume a standard approach to treatment. And this assumption can be especially problematic for older adults with multiple chronic conditions, which, as I say, are a substantial portion of the population of people with kidney failure in the US. So last, how do we improve this system to better support these ethical principles? Again, to zoom out, I think this response needs to address two main challenges. And this first is the tension between our wish and need to promote utility and to promote equity in using this adherence criterion. So in terms of promoting utility, we want to maximize the number of kidney years post-transplant. That might lead us to select those patients without any barriers to medication management who can engage with the healthcare system easily. On the other hand, respect for equitable access might lead us to select everyone who could benefit from transplant and even add support for those with challenges to healthcare access. The current state of things seems to suggest that there's more focus on utility at this point. And I think that's in part because of who's creating the rules of the system. For individual clinicians who are engaging the evaluation process, seeing the patient in front of them, I think there's more familiarity in kind of assessing relative utility in treatment options compared with patterns of equity or inequity across the population. We're just trained to understand utility in a way that we're not trained or have the global perspective to understand equity in the context of one individual patient. There's also incentives in place for transplant centers to maximize their one-year survival outcomes that are very forceful, but there's not really anything in the way of incentivizing equitable access. So transplant programs are beholden to these outcomes and are also very overworked and may have limited resources to proactively support people needing additional help. We're also encountering this overlap between resource allocation and clinical medicine. In a lot of care situations, care processes, we try to separate these two processes. So there's this substantial literature on the inherent problems with bedside rationing. Individual clinicians are not well positioned. They're not equipped with the right information to act as both a proponent for their individual patient and a gatekeeper of a scarce resource. But in the transplant evaluation process, and using adherence criterion as an example, this criterion could be framed as either supporting resource allocation and or ensuring that an individual patient stands to benefit from transplant. It's not explicitly clear where one goal starts and the other begins. So strategies to address, to improve the process, I think need to address both these challenges. And the first that I would suggest is to better implement these features of fair process. So that would be the idea that we should develop more standardized and transparent approach to adherence criterion. The idea here would be to also integrate public opinion about the relative importance of supporting equity, utility, person-centeredness. I would envision two kind of manifestations of this approach. One would be to have very inclusive, have a very inclusive approach where we only exclude those who would not personally benefit or might even be harmed from transplant because of barriers to adherence. In other words, we would make adherence criterion only focused on person-centered care, clinical care, and not so much about resource allocation. And then another option would be to develop specific measures of adherence agreed upon by the community and apply these measures in a standardized way. I think these strategies would address these tensions to some extent, would help to decide the relative weights of utility and equity and try to separate resource allocation and clinical medicine. It would be a step, but the evaluation and selection process is complex, and I think there's still going to be situations of ambiguity. And in that case, I think there's additional guardrails that we could put in place to limit the impact of biases and inconsistencies around adherence criterion. And that might include first bias training, ethics consultation, ethics review of practices around adherence criterion. So job security for a lot of the folks in this conference. And then we could also change some malaligned incentives for transplant centers to encourage broader access. So add resources to support post-transplant monitoring and management, such as more support for social workers and helping people navigate the system. So without all that, I'll close. But to review, we talked about adherence as a criterion for kidney transplant selection. We talked about ethical implications of this criterion for the perspective of utility, equity, and person-centeredness. And we ended with some potential strategies for improving the ethical foundation of the transplant selection process related to this adherence criterion. So thank you again. Thanks so much for attending. I think this is a really complex situation, but no group better equipped to work in this kind of nuance and complexity than those here, I suspect. So thank you again. Hope there's time for questions.
If you have any questions, feel free to raise your hand on the little function in Zoom. Otherwise, we have one in the chat that I can read out loud. It says, "Hi, thanks so much for this talk. Are there any tools clinicians can use in speaking with patients to reduce the moral injury in regards to language used around adherence? Example, do XYZ and you can get a kidney, when despite all the adherence a patient has, it's still not guaranteed. Or any reflections from patients on what they value from providers in talking about this?"
Those are exactly the kind of things I think we need. And I think individual clinicians that work with these patient populations are sort of developing their own strategies. Some of the work we're doing is qualitative work talking with clinicians about their experience and how they help manage patients going through this process, many of whom are from Harborview and work through some really complex situations with patients. And we're finding that people do kind of take on the role of coaching. What is this? They're going to ask you this, what does this mean? Have to play the game. that doesn't feel to me like a great long-term, end game solution, but we are finding that, people are coming up with these kind of middle ground strategies. But bringing that to the fore and making it more explicit what's happening here, I think would be a first step to really kind of intrinsically changing the process. Yeah, thanks for that suggestion.
Erin, if you want to come off mute.
Hi, Kate.
Hi,
Great
Erin.
talk as always. I was thinking about the second line of resolution of your idea of surveying the public, and whether that might lean towards a more inclusive or potentially exclusionary side. And there's a literature that Peter Ubel did a series of studies, and others did as well in the late 90s and early aughts, where they asked these sorts of questions, and the public came down on that more inclusive side. And the public also came down on we should exclude patients for other reasons, like if they had a condition that we felt maybe they caused it themselves, or potentially if they had fewer social resources. I don't have I'm not expecting an answer to this, but just to, but I'll ask you, one thing we can do is to look to public for attitudes, and OPTN did this in their now failed attempt to develop a new allocation schema where we asked about value prioritization exercises. In an effort to kind of understand what the public's views were. But what do we do when the public gives us views that we don't view as necessarily acceptable?
Yeah.
Does
No,
that provide the same guide?
I totally agree. I think that's a really difficult sort of thing to internalize. And I agree, it's hard, it's complicated to read those studies and try to interpret, where people are coming from. In my mind, and I'm not an expert, but I think there's a sort of a different approach of public deliberation in which there's kind of a structured approach of sort of informing sort of, for instance, ethics, people with ethics background, informing this public group about how to kind of weigh the different values, how to see the values underlying their initial instincts. So really bringing together ethics frameworks and public opinion to come to an informed consensus rather than initial inclinations that you might, see from a survey. So it is kind of that more deliberative process and intentional process that brings in these different perspectives in a structured way that to me seems like the way to approach that. And I think that OPTN, in developing the new rules and things, implemented these kinds of systems in pulling public opinions. But you have more experience with that. You might know. Not an easy question, but thank you.
We have a ton of questions in the chat and only 5 minutes left. So I'm wondering if you might share any of the emotional impact that you're aware of having to make transplant decisions. There's another question about dialysis and climate change, which highlighted the volume of freshwater need for dialysis. Do you foresee this affecting increased resource scarcity in the future? To what extent does insurance status impact fair distribution for transplantation? What are the funding options? Does Medicaid pay for kidney transplants? And when does adherence evaluation begin?
I think I have a one-liner for all those to kind of
Perfect.
No, I don't. Hopefully this is kind of fodder for future discussion, but I think the first question you asked was about the emotional implications or results of making transplant decisions. I don't know if the person asking the question had a perspective in mind that they were thinking, clinicians or patients, but and I just my first kind of reflection or interest on that question is that we did studies during the pandemic of clinicians facing these new situations where resources were scarce and they just hadn't encountered anything like this before, and there was huge moral distress, like very overt moral distress. When clinicians guide people through the transplant evaluation process, I do think one of the factors that shapes their response in terms of moral distress is that it's, you know, the process has been developed kind of slowly over time. There's been time to acclimate to this being kind of the norm. So pulling out what, you know, the underlying values of what seems normal, but may still have ethical, you know, we have ethical concerns about, again, I think is really important, making that transparent, and not just allowing the status quo. That's a partial answer to that more complex question.
Yes, the next question was dialysis and climate change, the need for fresh water for dialysis. Do you foresee this affecting increased resource scarcity in the future? Yes,
I do. There's a lot of work in green nephrology about anticipating how you know, how our impact on climate change, and also how climate change is going to impact the patient population, and you know, efforts to develop technologies that better utilize these resources, but also a really complex topic. There's some great literature on that out there, though, if you're interested.
And then the next two are about funding options, whether or not Medicaid pays, and what extent does insurance status impact fair distribution.
So Medicaid, Medicare does pay for transplant evaluation and transplant, and the particulars around that have evolved over time. I think the most kind of concerning effect or population that's affected by that is people who are undocumented, who are not able to get Medicaid in some states. And that has also been an evolving landscape over the last few years, with a lot of advocacy work to get support for that. But yes, so in some situations there are financial limitations to getting on the transplant wait list.
I'm sure there's a whole talk on that.
Yes, it's a big topic too. Of course,
The
there wasn't any softballs.
The next question is, when does adherence evaluation begin? You mentioned it's over a long time, but what does that mean?
Yeah, and I think the short answer is that it's hugely variable by individual, you know, even nephrologists who might kind of anticipate this being an issue down the line, start thinking about it for patients. It's just, there's no consistent approach across transplant centers or regions.
And then our last question, so sorry, Jenna, if you want to come off mute.
Mine was more a comment that we face very similar issues. I work at Harborview, so we have a lot of people who are, quote, not adherent. We're not compliant. I hate that, but that's really the judgmental word. We face this a lot with joint replacement surgery, and we also face it a lot with cancer treatment. People cannot access those things even with our own system because they're deemed as non-compliant. And also there are personal factors that cause these problems. And this is among the medical providers. So just wanted to throw that out there. If you're in social work, you know what I mean.
Right. And I agree. I mean, in the last, or I guess we're at time now, but I totally agree. That's a really interesting sort of paradigm or kind of case comparison, what's different and what's similar between these two different settings, and I think pulls out a lot of the kind of underlying ethical conflicts. So I agree, that's a really interesting case situation to consider, and there's definitely some parallels and some things that are different. Yeah, thanks, Jen.
We are at time. Thank you so much for everyone attending. If you are a UW learner, please fill out that Microsoft Forms survey to record your attendance. And thank you so much again to Dr. Butler for this amazing presentation.
Thanks, Carrie.
All right. Have a great day, everyone.